Welcome to Bear in Mind, the Brown Psychiatry Podcast, clear, current content about mental health. I am your host, Dr. Tracey Guthrie, Psychiatry Residency Program Director and Co-Editor-in-Chief.
I'm the co-host, Dr. Camila Cosmo, Brown Assistant Professor and Co-Editor-in-Chief.
And I am Dr. Meghan Kulak, Psychiatry Resident and Script Editor for today's episode.
I'm Lewkowitz. I'm a high-risk pregnancy doctor at Women and Infants Hospital who specializes in doing research in digital health and also mental health in the perinatal period.
Welcome.
Thank you for having me.
It's our pleasure. First, a content warning.
In this episode, we will talk about sensitive topics, some of which you may find triggering. Our only purpose is to provide education and information. Our content is not to be considered medical advice. Pregnancy and childbirth are often painted as the most beautiful things someone can experience. While that may be true for some, there's another side to the story for many parents. Depression and anxiety are very common, though rarely discussed as part of someone's pregnancy journey.
From the moment a pregnancy is confirmed to the weeks following childbirth, we can all imagine a certain level of anxiety and new emotions new parents might feel. But when do these feelings become problematic? We hope to find out more on this important topic in today's episode.
Today, we'd like to welcome Dr. Adam Lewkowitz, who joins us to talk about perinatal mental health. Dr. Lewkowitz is a board-certified OBGYN specializing in maternal-fetal medicine. He is an assistant professor in the Division of Maternal-Fetal Medicine at Brown and works at the Women and Infants Hospital. Welcome, Dr. Lewkowitz. It's our pleasure to have you.
Thank you so much, and I'm excited to be here.
Excellent. So could you please start by defining perinatal for us?
Yes, that's a great place to start. So perinatal is a word that we use often, and basically it means the period from the moment that you become pregnant until a year after childbirth. So it's really, 19 or 21 months, actually. So it can be quite...
It's a long period of time.
It's quite a long period of time.
Dr. Lewkowitz, we are wondering how common are anxiety and depression during and after pregnancy, and how long might it last?
Those are great questions. So the thing that's really tricky is actually about 80% of people who deliver get what's called postpartum or baby blues.
Mm-hmm.
And baby blues are essentially the same symptoms that you think about when you have mood disorders like anxiety or depression. You can feel restless, anxious, depressed, sad, feeling useless, crying all the time without reason. But the key differentiation between the baby blues, which is thought to be a very normal process, and postpartum anxiety or depression, is that the baby blues starts right off the bat within a few days of delivery, and then it ends within 2 weeks.
Mm-hmm.
Whereas when you have postpartum depression or anxiety, it generally starts about 1 to 3 weeks after delivery. And you might have the same symptoms, but they're much harder to navigate and they don't go away. In terms of how common they are, we think about 1 to 5 or 1 in 6 birthing people develop postpartum depression or anxiety, which makes it the most common condition that we face in the perinatal period.
Mm-hmm. And is there anything different about anxiety and depression during this period compared to other times in your life?
Question. You guys are good with these questions. In general, the symptoms are very similar. So the same things that you think about for birthing people in the non-perinatal period in terms of depression or anxiety, you would have those symptoms. But what really kicks it up a notch is the baby.
Yeah.
Because when, even if you have read online or heard that a baby sleeps, eats every 2 hours in the first few weeks of life, nobody realizes that that's like, 30 minutes to feed the baby, 30 minutes to clean the blowout diaper, and the new clothes, 10 minutes to put the baby back to sleep. And all of a sudden you only have 20 or 30 minutes to actually sleep before the cycle starts. And it's just this relentless monotony of caring for something that really can't engage back with you.
Mm-hmm.
And then on top of that is they can't communicate. Right. So you have no idea when your baby's screaming if something is wrong, if you're doing something wrong, if they're in pain. And so it just adds this whole another layer of stress that makes it very easy to kind of fall into feelings of worthlessness or anxiety.
And I know you kind of talked a little bit about some of the symptoms that might go along with anxiety and depression in this period. But we're wondering if you could talk a little bit more about what people can look out for during and after pregnancy in terms of anxiety and depression.
Yeah. I think, just like outside of pregnancy, if you're feeling an overwhelming sense of guilt, sadness, or panic, or doubt or lack of self-worth. These are all symptoms that can feel very normal to parenting, but like anything, if it crosses the threshold, you get so worried about making a mistake that you're unable to leave your house because you don't want to forget something important for your baby, or you feel like you can't get dressed, then those are things that you definitely should reach out to get help for. The most important thing above all is it's never normal to have thoughts that you want to hurt your baby or yourself. So if you ever have those thoughts, don't feel embarrassed or ashamed. Call an ambulance, and you'll be welcomed by your healthcare team, because we will be very excited that you were brave and courageous enough to recognize that you had those feelings and act on them before you took potentially this step of causing harm.
And we are wondering, is there any difference in how birthing and non-birthing parents experience mood and anxiety symptoms?
Great question again. So in terms of how common it is, in terms of postpartum depression, about 12 to 15% of birthing patients are diagnosed with postpartum depression. And that's pretty high. But what's really interesting is anywhere from 8 to 12% of non-birthing parents are also diagnosed with postpartum depression, which to me is very striking, because we're finally starting to recognize in the obstetric community that the mental health burden is very heavy with our patients, but we still continue to treat our moms or our birthing patients in isolation, ignoring the context in which they live. And so the symptoms, so two things. First, we know that if one of the parents has depression or anxiety, it is much more likely for the other parent to develop the same condition. So it's a major risk factor. And the second is it can be really tricky for non-birthing partners, especially if they're men, to recognize their symptoms as depression, because they might have been brought up in an environment where men aren't supposed to have emotions, or they might not recognize that they're having these emotions. And then they turn this like unease that they're feeling into, I don't know that I'm not a psychiatrist, but like malignant coping strategy, something that's like not a healthy way to respond. So it's either ignoring the family by like playing video games all the time, going out with friends, never coming home, or turning to drugs and alcohol. And then even if you do recognize, because a lot of men might not have primary care providers or engage with healthcare, they don't know where to go. So there's a lot less screening of people who recognize, much less a lot less treatment. So it's a really growing area of research in the perinatal mental health space to recognize that we can't just view the birthing patient as the sole, patient that we're dealing with. We're really needing to view the family as a whole.
Interesting.
Yeah, I think that's so interesting, because I think we often think of postpartum depression and anxiety being so connected to hormonal fluctuations. And here, from what you're saying, there is such a large component of how that family's functioning and how they're adjusting to the birth of the new baby.
Oh, exactly. Like I don't think you understand. It's impossible to understand what it's like to take care of a baby until you have it happen to you.
Right.
And every single family unit has to navigate that like very profound life transition in a way that you try to survive and ideally thrive, but that's basically impossible in the beginning. Not to be too negative. Kids are great. They're the best. But
Well, I'm wondering, given all this, what are the treatments for perinatal psychiatric disorders? And I'm wondering as well, are these treatments safe for baby?
Great question. So one of the things that I feel like is most important in my job as a high-risk pregnancy doctor is I'm often kind of the bridge between two different services. And so you have the OBs who are excellent at taking care of pregnant people, and then you have specialists like psychiatrists or whatever who are excellent at taking care of non-pregnant people. And sometimes there's this big gap, and we try to just fill that. And the reason I say that is one of a very striking statistic that always kind of keeps me up at night is, according to the research, about 80% of people who are stable on their psychiatric medicines are told to stop those medicines during pregnancy. And the vast majority of psychiatric medicines are completely safe. Every medicine you take has risk, because everything has risk, but the very slight risk of having a minor birth defect from our perspective is way less than the known risk of having a relapse of pretty profound depression, which will happen or is more likely to happen than not, particularly after the baby's born. So we often encourage patients, particularly those that you probably have taken care of that have needed 4 or 5 different regimens to come up with something stable.
Right.
Don't rock the boat. This is not the time to change things. We will help you get through, making sure that they're all safe. But even, we were just at our big high-risk pregnancy conference, and one of the medicines that historically we were told was like almost never to use, they're now knowing that the increased risk is still so small that this huge center in New York City has stopped telling patients to stop because it's one of the only meds that works for a lot of patients. And that was really eye-opening for me.
To that point, what are the consequences that we can see with untreated anxiety and depression?
So I don't mean to be dramatic, but the Center for Disease Control and Prevention, the CDC, just released data in October of 2023 that said that almost 1 in 4 maternal deaths after delivery were due to maternal mental health conditions. And it's not the purest composite because it includes that composite that they included. It wasn't just, depression, anxiety. It was suicide. It was accidental trauma. And it was overdose. So I don't want people listening to be like, if I'm depressed, I might commit suicide. Like that's not the take-home message, but just the point that this is a major driver of horrific outcomes. And because of that, our community really is being more attuned to the consequences. Much more common what happens is that people who are stable on their meds or stable off of meds have a relapse of their symptoms. And in the best case scenario, they recognize that and they, get teed really quickly into help and they get through the process relatively quickly back on their feet.
And could you please comment, what are some common sources of anxiety for new parents that people don't often anticipate?
Great question. So I'm going to get on my soapbox for a little bit because I think probably 10 or 15 years ago, it was easier to be a new parent than it is now. Because 10 or 15 years ago, you would get advice from your parents or your friends who had babies, or you'd be at the playground talking to new parents and being like, wow, last night was horrible. Was it bad for you? And it was this sense of community. But now what's happening is all of the social media channels are flooded with these perfect parents whose kids always look beautiful and they always have they always eat the food that's provided to them. And it's just kind of creates this cycle of perfection that's impossible. And I think that it's not really an answer to your question, but I do think that that's a major driver of feelings of inadequacy and powerlessness and helplessness, which could then, steamroll into depression or anxiety. But then I think, honestly, just the unrealistic expectations that we're talking about. But I think the other thing that can really cause anxiety, and not to get too personal, but as I said before, you don't know how to take care of a baby until you try.
Right.
And so there's just tremendous feelings of inadequacy and conflict between a partner that you've loved forever. All of a sudden you're screaming at each other at 3 a.m. because your baby won't stop crying. And neither of you know why. And you're just trying to navigate it together. So I think there's these external stressors that your life is not living up to what you see on Instagram or TikTok. And then there are these really real stressors where you can't figure out how to make your baby stop screaming.
Right.
Or how to deal with your mother or your mother-in-law who just used to be lovely, but now drives you crazy. And stop advice.
All while sleep deprived.
All while sleep deprived. All while sleep deprived. Exactly.
I'm kind of wondering, given that this is such a common experience from what you were saying, why do you think this topic is so rarely talked about?
Oh, that's $1 million question. I think despite kind of our awareness that mental health is health, there's still a stigma. And I do think that just, I've been a MFM, a high-risk pregnancy doctor for 5 years. And even in those 5 years, there's really been a lot more transparency and openness. And I attribute that to Simone Biles and Michael Phelps being very open about their burdens. Because if these the best Olympians in the world can admit that they're struggling, then of course everyday people can admit that too. I also think one of the things that we are getting a little bit better about in obstetrics is we as OBs historically didn't know what to do when people
Right.
Like we knew we had to have people fill out an EPTS, which I know can be problematic in your circles. But when they would come back with the scores and they'd come up like very clearly screening positive for depression, we'd be like, oh God, like what next? Like, there's, who do we call to it? And it became this thing. And now we integrate mental health screening as part of our routine intake visit for every single patient. And we do it usually after the food insecurity screen. So it's like, oh, this is just what this clinic does. It's not because they think I'm depressed.
Right.
So it really normalizes it, and we screen multiple times. So I'm hoping that the stigma is going away, but it definitely is stigma.
Mm-hmm. And also that helps you make connections with providers. Yes. Like if you're screening a lot of people, you have to make connections with providers so that okay, well, I know what to do now. I know what to do myself or to start, or I know who to send people to. It's not just screening and then saying, oh, I don't know what to do with the screen. But when you do that for a bulk of people, it normalizes it on both sides.
Yes.
For the physician, or the practitioner, and the patient.
Yeah.
So that's
very well put.
So what can partners, family, friends do to help their loved ones who are struggling with anxiety and depression during this perinatal period?
This first comment is really not rocket science. It's almost embarrassing to say, but I think it's really the most important thing you can do, which is go to classes and learn how to take care. Like, don't just go to the birthing class. So my oldest child is 10, and we were living in San Francisco at the time. And my wife, it was really important that I went to the birthing class, and it was only $10 more to go to the breastfeeding class and the baby care class too. So I was like, okay, whatever. I'm a resident. Might as well go. I already know the birth part as an OB resident.
Right.
And at the birthing class, every single birthing partner had a non-birthing partner there. Every single one out of the 30. The breastfeeding class, I was one of 2 non-birthing partners. And the infant care, I was the only one. And my wife ended up having an unplanned C-section in the middle of the night. I had never held a baby in my entire life, aside from a second.
Right.
Someone gave them to me.
Right.
And the nurse left the room. My son was screaming in the bassinet. My wife was still with her anesthesia. She could not move. I was like, wow, this is my time. And because I went to those classes, I could pick the baby up. I could hold the baby. And then I also felt really a lot more helpful with the breastfeeding process, because it's hard. That's another thing that people act like is so easy. It is not easy.
Right.
And it hurts in the beginning often, and it's just a struggle bus. And if you, as the non-birthing partner, educate yourself, you can actually help. And so it sounds really simple, but sign up for those education classes. And then if your partner is showing signs that maybe they're not acting the same way, because you know them best, right? So if they're acting down, they're acting really anxious, help them destigmatize those emotions and say I feel that way too, because I'm also exhausted, but it seems like you might be getting a little bit where I'm worried about you. Have you told your OB about this? Have you told your midwife? Or if it's a few months after delivery, have you told your primary care doctor? There's a lot of resources that we can help you.
And talking about those parents that are expecting or that are just new parents, could you please recommend some local and national resource?
Yes, I'm happy to. So for people listening who live in Rhode Island, I swear I don't get a kickback for this, but Women and Infants Hospital, we're not just an amazing birthing hospital. One of the reasons that we're so amazing is that we have very well integrated perinatal mental health services that are really a seamless part of the care we provide in our clinics as well as in the hospital. And it's all different levels. So some people just need a social work visit to kind of check in to hear that someone's listening to them, that they have a choice, that if they need an escalation, there's the... Some people need, therapists. Some people need, actual psychology therapy, and some people need medications, and some people even need to be, go to the day hospital. But it's all there, and it's very easy to kind of scale up as you need it and scale down as you don't. Right. And I think that most kind of tertiary care academic centers, particularly in the Northeast, have that type of resources. But if you're listening and you don't, have the privilege of living in Rhode Island, if the most important thing I'll tell you, and I'm going to look down to make sure I tell you the number right, is that one of the things that they have done recently is the National Maternal Mental Health Hotline, which we are actually giving all of our patients a magnet to put on their fridges.
Oh, nice.
Because it's 24/7. It's in English and Spanish. And their goal is to help triage. Like, first of all, they're there to listen at 2 a.m. when you're at your darkest moments, and they will help you get the care you need locally. And that number is 1-833-TLC-MAMA, like tender loving care, or 1-833-852-6262. So just, no, like I said earlier, we're not at the point of medicine anymore where, OB providers judge you for anything, but particularly for mental health needs.
Right.
So never feel like your midwife, your nurse practitioner, your doctor is going to be like, oh, like you're just not tough enough. That was like 1980s, 1970s. Like, we realize now that the most common condition we treat among pregnant people is mental health. And we have to embrace that and support our patients in that way.
Sure. Absolutely.
I was wondering if you could tell us a little bit more about your research and what you've been studying.
Yeah, I'm happy to. So I have a K-23, which is a training grant to teach me more about mental health, because I am not a psychiatrist. So this is where I want to kind of have a lot of my clinical time, and also digital health and qualitative research. And what I'm doing in this grant is adapting a cognitive behavioral therapy program that has been shown to prevent postpartum depression when given in English or Spanish during pregnancy in groups, adapt that evidence-based curriculum into a smartphone app to make it accessible to a lot more patients. And so that's what I've been working on quite a bit. And then through the qualitative research, actually, that's where my interest in helping non-birthing partners started, because a recurrent theme was like, my partner did nothing. Like I was drowning, and he didn't help, and he said he didn't know how. And that's not really a good excuse. And so one of the things I'm starting to work on, I'm almost done now with the first draft and about to start the qualitative research, is creating an interpersonal therapy-based intervention to try to teach non-birthing partners. And at this point, it's going to be very gendered because it's just going to be for men. But the goal eventually is to make it more acceptable for everyone. But that teaches new dads how to be fathers and how to be partners to a new mom on all different levels. And it's really interesting to do that, because there's really nothing out there right now. So,
very much needed.
Yeah.
Very much needed. Let's talk a little about cultural perspectives and what you've seen in your clinical experiences and what your research informs you about. And give us a little sense about what are the differences that you see, what are the differences you don't see in any of those roles.
Great question. So I think from a research perspective, when I was early on adapting this program to an app, you make these wireframes, and I made them similar originally to make it easier for me. But I was anticipating that over these interviews, they would really become divergent based on what people from different cultures wanted, and they did not. So that made me realize that I think it's just hard for everyone in kind of the same way. Or it could just be I need to do more work and figure out the actual nitty-gritty differences. And there are, of course, certain cultures where the mom gives birth and then they go in the house for 30 days and have to eat warm foods or whatever the culture is. But I think kind of the recurrent theme of whatever your culture is that there are gender expectations that can be very clearly defined and very difficult to change, particularly if your culture prioritizes parents and grandparents of the birthing person being really involved early on. That can feel very difficult, patients have said. Or people who grew up in a country in a certain way and now are living here and don't want to do that. And then their parents are flying in for like 3 or 4 months, and it's like a ton of tension. But yeah, I think there are obviously cultural differences, and I don't want to downplay them, but the postpartum period is just difficult.
It's just hard.
It's just hard. Yes.
And could you provide any advice for parents that are right now surrounded by friends, family, as you mentioned, that have strong opinions about how they should be parenting. And we know that a lot of people, they comes from a good place, like they intend well, but this can be overwhelming, as you were mentioned. What would advise them? How can they navigate those circumstances?
So I think you have to view the process as a war and not a battle. So you have to decide what do you need to do to kind of win the war. And the war is the parent, like bringing your child up the way you want to bring your child up. And so if you have to decide what hills you're going to die on, what's really important to you, and those are your sticking points, and what is like really important to your parents, but you don't really care about.
Right.
And so, it's constant back and forth, but everybody is different. It makes it seem like psychological warfare, and sometimes it can feel like that. The other thing I would say that has been really helpful on a personal level, and I don't know, I'm curious as to your experience, is really viewing your family as your problem and your partner's family as their problem.
It is incredibly helpful. Yeah. Again, there's no lightning bolt.
No, it's all work. So
thank you very much. This conversation was very helpful. So I hope everybody could appreciate that. Thank you for joining us.
My pleasure.
So now a take-home message to bear in mind.
So we've learned that perinatal mental health disorders, especially anxiety and depression, are more common than we realize. It's important for both the person experiencing these symptoms and their support networks to recognize these signs and seek help. And just a programming note, we had another episode with Dr. Jessica Pineda, Mental Health and Pregnancy, which really also answers some questions about medications and the benefit of these medications, and also risks and benefits and their safe use in breastfeeding and for the baby. So please check that out as well. It really dovetails very nicely with this episode.
We hope you had a nice time learning more about perinatal anxiety and depression with us today. And by having open conversations, seeking support, and challenging stigma, we can all help make pregnancy a more positive experience.
And as always, if your loved one is having suicidal thoughts, please contact the Suicide and Crisis Lifeline, call or text 988, or access 988lifeline.org. The Lifeline is a 24-hour toll-free phone line. You can also go to the nearest emergency room and ask for help.
Thank you for listening to our podcast. For more information related content, please check out our Instagram, X, Facebook, and YouTube channels. Bear in mind the Brown Psychiatry Podcast. Thank you.